Hi, my name is Anne Graff-Ladisa, and today I will be talking to you about the pharmacology of antiplatelet and anticoagulant drug therapy used in the ambulatory care setting. In this discussion, we'll first review the mechanisms of blood coagulation, and the majority of the discussion will be the explanation of the pharmacology as well as some discussion of the different agents that are available. And then we will briefly review the pharmacotherapy guidelines for antithrombotic therapy in atrial fibrillation and prosthetic heart valves, and we will also review pharmacotherapy for the treatment of venous thromboembolism. There are two functional units of blood coagulation, platelets and fibrin. Platelets, which start the clotting process, and fibrin, which is a portion of the blood clotting cascade that forms the actual clot complex. So there are many steps to forming a clot, but to form a good clot, we need three primary essential steps. We need to form prothrombin activator, or factor Xa, and platelet activation and or tissue damage will initiate this process of forming factor Xa, which we'll review in the next couple slides. We also need prothrombin activator, or factor Xa, because it converts prothrombin to thrombin. And then thrombin is important because it transforms fibrinogen to fibrin, which is the essential ingredient needed to reinforce the clot for long-term effectiveness. To break thrombogenesis down even further, starting at the top of this slide, whenever there is a defect in the blood vessel wall or some endothelial injury, platelets adhere to exposed collagen of the damaged endothelium and become activated. Now, activated platelets release adenosine diphosphate, or ADP, serotonin, which is 5-HT, and thromboxane A2, or TXA2. These then activate additional platelets, and platelets begin to aggregate. The aggregated platelets start to lose their individual membranes, they release their contents, and form a gelatinous mass. This mass, or platelet plug, quickly stops the bleeding, but it needs fibrin as a reinforcement to make an effective clot. So the aggregated platelets activate the clotting factors of the blood coagulation cascade, which leads to the formation of fibrin. Now, of course, we have to have a negative feedback system incorporated into this process, and that's represented here by the prostacyclin, or PGI2. PGI2 is synthesized within the vessel wall and inhibits thrombogenesis. We'll see later on in the lecture how antiplatelet medications interfere with the process of platelet activation and aggregation that is shown here. This is a somewhat simplified figure of the blood coagulation cascade. The clotting factors are represented by the Roman numerals, and at each step, a clotting factor undergoes a conversion to an active clotting factor. Those are the Roman numerals with an A after them. So, for example, factor 7 is inactive, but factor 7A is the active factor 7. So these activated factors then catalyze the next step in the cascade, and it goes on, ultimately resulting in the formation of fibrin. This cascade is important when we begin to talk about the mechanisms of action of anticoagulant medications and how they interfere with the process shown here. We'll begin our discussion of drug therapy with antiplatelet therapy. Antiplatelet therapy is used to decrease platelet adhesion and aggregation, and there's a variety of indications for antiplatelet therapy. Some include the prevention of atherosclerotic events like stroke, TIA, MI, vascular disease, preventing complications after coronary stenting, and adjunctive therapy in the revascularization process, such as CABG or PTCA or carotid endarterectomy. Also, acute coronary syndrome is another indication for which antiplatelet therapy is used. The antiplatelet medications that we'll cover today in this lecture are aspirin, dipyridamole and aspirin, ticlopidine, clopidogrel, prasugrel, and ticagrelor. Beginning with aspirin, aspirin inhibits platelet aggregation by inhibiting the synthesis of thromboxane A2, which, as we know from a previous slide, causes platelets to activate and aggregate. Aspirin inhibits the synthesis of thromboxane A2 from arachidonic acid by irreversibly acetylating the enzyme cyclooxygenase. Aspirin is absorbed in the stomach and intestines, and The antiplatelet effect for conventional aspirin occurs in about an hour, and with enteric-coated aspirin, it occurs in about 3 to 4 hours. So if rapid antiplatelet activity is necessary and only an enteric-coated aspirin is available, you need to chew the tabs. So an example of this would be when you need a rapid antiplatelet effect is if someone is having an MI and you only have those enteric-coated aspirins, they need to chew them. Also, the half-life is about 15 to 20 minutes, but it has a prolonged antiplatelet effect. And this goes back to the irreversible inactivation that I talked about in the previous slide. Platelet inhibition effect lasts for the lifespan of a platelet because aspirin irreversibly inactivates the platelet enzymes cyclooxygenase. So what this means is that since about 10% of circulating platelets are replaced every 24 hours, about 5 to 6 days after taking aspirin, about only 50% of platelets are functioning normally. And platelets cannot manufacture a new enzyme in their 10-day lifespan. So an example of some other medications like NSAIDs, which are ibuprofen and naproxen, they also inhibit cyclooxygenase, but their action is reversible, so therefore they have a shorter duration of inhibitory effect. We know that we dose aspirin once daily when we're giving it as an antiplatelet because it knocks out thromboxane A2 production for the life of the platelet. But how do we know what dose to use? Do we use 81 milligrams? Do we use 325 milligrams? Well, the right dose varies for the different vascular disorders. We do know from studies that aspirin lacks a dose-response relationship, meaning that increasing the dose of aspirin used in a specific disorder doesn't necessarily improve our outcomes. But we also know that unwanted side effects of aspirin are dose-dependent. So it's recommended that we use the lowest dose shown to be effective in a particular indication. I've included on this slide a summary table of these doses, which is from the 2012 CHEST guidelines on antithrombotic and thrombolytic therapy from the section on antiplatelet drugs. This is the most recent version of the CHEST guidelines that is available. You can review these doses at your leisure. Toxicity and monitoring for aspirin. This is going to be a common theme in this lecture, an adverse reaction of bleeding or monitoring for bleeding. There is an increased risk of bleeding with an increased dose of aspirin, and use of aspirin with other anticoagulants and other antiplatelet medications increases this risk of bleeding as well. So we do not use aspirin in active bleeding, such as people with peptic ulcer disease or intracranial hemorrhage, and we want to monitor for signs and symptoms of bleeding with aspirin use. It can also cause stomach upset because aspirin has a strong affinity for cyclooxygenase and it inhibits the cyclooxygenase wherever it's found. So cyclooxygenase is also found in the intestinal mucosa. So we also decrease the protection of the stomach lining from acid when we're giving a patient aspirin. Now, the effect of aspirin is dose-related, so lower doses are used for antiplatelet indication versus an analgesic. So maybe stomach upset is not much of a problem for your patients who are on once-a-day aspirin. When discussing aspirin, I also wanted to mention that in 2006, the FDA issued a statement informing patients and healthcare professionals that ibuprofen can interfere with the antiplatelet effect of low-dose aspirin, which is generally considered to be about 81 milligrams a day. And it potentially renders the aspirin less effective when used for cardioprotection and stroke prevention. It was also noted that other non-selective over-the-counter NSAIDs, such as naproxen or ketoprofen, should be reviewed as having the potential to also interfere unless proven otherwise. The mechanism by which this occurs may be through competitive inhibition, so NSAIDs also acetylate the enzyme cyclooxygenase. So if taken concomitantly, both ibuprofen and aspirin occupy nearby receptor sites on cyclooxygenase, such that the presence of the ibuprofen would interfere with the aspirin binding. So healthcare providers are encouraged to counsel their patients to time their doses of NSAIDs 30 minutes after or 8 hours before their aspirin dose to avoid this interaction. Moving on to dipyridamole. It works by inhibiting cyclic nucleotide phosphodiesterase, which is an enzyme that degrades cyclic AMP within the platelet. So by inhibiting this enzyme, you get cyclic AMP accumulation, which leads to platelet inhibition. It also stimulates prostacyclin synthesis, which is a component of our negative feedback system that I talked about earlier, and it also has vasodilatation properties. Now, there is variable absorption in the conventional formulation of dipyridamole, so that results in a low systemic bioavailability of the drug. So the question was then raised, well, can the plasma concentrations of the drug needed to establish a clinically significant platelet effect be achieved after oral administration? Well, the company developed a modified release formulation which combines low-dose aspirin, and it also improves availability. And this is available as what we commonly know as Agrinox, which is dipyridamole and aspirin combined in one capsule, which you take twice daily. This medication is only approved for the use in secondary prevention of TIA and stroke. The most common side effect reported with dipyridamole is headache, which could possibly be due to the vasodilatation effects of this drug. Also, we need to monitor for signs and symptoms of bleeding. And it's also important to note that the capsule should be swallowed whole because it is an extended release formulation. The other antiplatelet agents we'll discuss are clopidogrel, ticlopidine, and prasugrel, which are all phenylpyridines. And then also ticagrelor, which is in a new chemical class called cyclopentyltriazolopyrimidines. No, I'm not kidding. It has 31 letters in that class. So this is a newer agent that's on the market. Their antiplatelet effect on all these drugs comes from the inhibition of the ADP receptor on the platelet. And they differ from aspirin in the fact that they have no effect on prostaglandins, so we don't have to worry about the GI mucosa side effect. These agents irreversibly bind to the platelet for the life of the platelet, with the exception of ticagrelor, whose interaction with the ADP receptor on the platelet is reversible, which impacts its duration of effects, and we'll talk about this later. We'll start with clopidogrel, which is dosed typically at 75 milligrams a day. Often in ACS, the loading dose of 300 milligrams or 600 milligrams is used, and then you use a maintenance dose of 75 milligrams. The antiplatelet effect of the loading dose usually occurs about 2 hours after the dose, and with conventional dosing, it happens on about day 2 of therapy. There is a cumulative inhibition of platelet function that is similar to aspirin after the repeated dosing with clopidogrel, and the platelet function would return to normal after about 7 days. And just to note, when someone is going to have surgery, you need to stop the antiplatelet. You need to stop it about 5 to 7 days before the surgery to be safe. Drug interactions for clopidogrel, it is extensively hepatically metabolized and is a weak CYP1A2 and 3A4 activity. So therefore, macrolide antibiotics, atorvastatin and simvastatin may attenuate the effects of clopidogrel. There is also increased risk of bleeding with other anticoagulants or other antiplatelet agents. However, it's important to note that the concurrent use of clopidogrel and aspirin is often seen. With monitoring and toxicity, we have to monitor for bleeding. Again, do not use inactive bleeding. And then also there have been some cases of TTP that have been reported, usually in the first 2 weeks of therapy. Ticlopidine has really fallen out of favor in usage compared to other antiplatelet agents, and this is mainly because of the adverse drug reactions that we can see. You can see hypercholesteremia with ticlopidine within about 1 month of treatment, and then also probably the most severe is the bone marrow toxicity that can be seen. It's a rare but serious ADR. You can see neutropenia sometimes within the first 3 months, and there's also potential risk of thrombocytopenia, aplastic anemia, and TTP. There's also a slow onset of antiplatelet effects with ticlopidine. The onset is about 6 hours and it peaks at about 3 to 5 days. So really, Ticlet is not useful when a rapid antiplatelet effect is required. And also a loading dose is not used likely because of its safety profile. These next two agents you won't be prescribing much in primary care, but they're mainly used for unstable angina, non-ST elevation MI, and ST elevation MIs that are managed with PCI. But you might see them in your patients that are also being managed by a cardiologist, and I also want you to be aware of them and their potential side effects and toxicities. Prasugrel has a higher and more rapid and consistent platelet inhibition than clopidogrel, according to studies, but potentially there is more bleeding risk. It is contraindicated in active bleeding, as some of the other antiplatelet agents that we've talked about, and it's also contraindicated in patients with a history of stroke or TIA. So you won't be using this agent for secondary prevention of stroke like you may use aspirin or Agrinox or clopidogrel. Some additional risk factors for bleeding are in patients that are greater than or equal to 75 years old. And in this case, it's generally not recommended that these patients receive this drug because they had higher rates of bleeding in the initial clinical trials. Specifically with 75-year-olds, a higher risk of fatal and intracranial bleeding with uncertain benefit. So it's generally just not recommended. You also have to use caution in patients that are small, less than 60 kilos, and when using other medications that can increase bleeding risk. Loading dose is 60 milligrams given in the cath lab and then 10 milligrams daily as maintenance. Other infrequent ADRs are thrombocytopenia, anemia, abnormal LFTs, and allergic reactions and angioedema. Ticagrelor is also used for unstable angina and non-ST elevation MI, and ST elevation MI is managed with PCI, but is not indicated for stroke prophylaxis. It does seem to have a better efficacy than clopidogrel with similar risk of bleeding in most cases, according to the studies that have been done on this drug. It does have a quicker onset of action because it is not a prodrug as the last three antiplatelet agents that we've talked about. But it does have a shorter duration of action because of its reversible platelet binding. So as you notice with the dosing, the maintenance dosing is dosed twice a day versus once a day, as we discussed with previous agents. Something interesting about this drug is that the maximum concurrent aspirin dose that you should use with it for the maintenance dose is 100 milligrams a day. This is because they have seen that aspirin doses that are greater than 100 milligrams were associated with decreased effectiveness of ticagrelor. Also, it's contraindicated in active bleeding in patients with a history of intracranial hemorrhage, and you have to use caution when you combine it with strong CYP3A4 inhibitors and inducers. Other ADRs that you can see, it's been reported that dyspnea is common in the first week of treatment, but usually goes away after that first week. The cost of antiplatelet agents is definitely something to keep in mind when you're thinking about antiplatelet therapy for your patients. Clopidogrel, which is the brand name is Plavix. Plavix's patent expired in May of 2012. So with the generic available now, the price has decreased by about $180 a month. And as you can see, agents with no generic available continue to be expensive for a month's supply. Now we'll move on to the anticoagulant medications. We will be discussing low molecular weight heparins. And although there are others, the two commonly used ones are enoxaparin and dalteparin. We'll talk about fondaparinux, which is a similar mechanism of action to the low molecular weight heparins, but it's a completely synthetic compound. And we'll also discuss warfarin, dabigatran, and rivaroxaban. We're not going to be discussing unfractionated heparin or IV heparin today because the focus is on medications used in the ambulatory setting. Low molecular weight heparins are used in the prevention and treatment of venous thromboembolism and the prevention of ischemic complications from unstable angina and non-STMI and STMIs. The mechanism of action is that they inhibit factor Xa, and they're called low molecular weight heparins because they're about a third the molecular weight as unfractionated heparins. So these smaller fragments have a reduced ability to inactivate thrombin, but they inactivate factor Xa almost as well as larger molecules. Therefore, they have a more predictable dose-response relationship than unfractionated heparin. This is our slide of the coagulation cascade, and I've drawn a box around factor Xa, which is what the low molecular weight heparins inhibit, to give you an idea of where it is in the cascade. Low molecular weight heparins are given by subcutaneous injection. Their peak anti-factor Xa activity happens in about 3 to 5 hours, and they have a more predictable dose response than unfractionated heparin, as we talked about. Half-life is about 3 to 6 hours, and this is longer than unfractionated heparin, but it's not dose-dependent. So, based on this pharmacokinetic information, it's reasonable to use low molecular weight heparins in weight-adjusted doses without the PTT monitoring that is required for heparin. Also note that low molecular weight heparin undergoes renal elimination. The dosing for low molecular weight heparin varies with indication. For prophylaxis, we use fixed doses like the ones listed here for enoxaparin and dalteparin. And this would be, and examples of these would be like for post-op prophylaxis for hip and knee surgery or prophylaxis for non-ambulatory medically ill patients that are in the hospital. With therapeutic dosing, which is for like the treatment of DVT or PE or treatment of ischemia due to unstable angina or non-ST elevation MI, we use weight-adjusted doses as shown here. The doses for enoxaparin and dalteparin are weight-based. Now, there are some special populations for which the dosing is modified, and these are our obese patients and our patients with renal dysfunction. In obese patients, the theory is that since there's not a direct relationship between intravascular volume and total body weight, there's the potential to overdose obese patients if we dose based on strict body weight without a ceiling dose. So some researchers got together and did a meta-analysis looking at the use of low molecular weight heparins in obese patients at therapeutic doses. They found that those with a BMI of greater than 30 didn't really have the increased bleeding that they had theorized. So the recommendation is to use actual body weight in these patients. However, there were very few patients with BMIs greater than 50 in this meta-analysis. So for those patients, they do recommend monitoring anti-factor Xa levels. Now, anti-factor Xa levels can be drawn, by the way, to evaluate for potential toxicity. If they are elevated out of the normal range for efficacy, the patient can be at risk for bleeds. In the clinical setting, you would draw them 4 hours after the injection is given. Researchers also looked at studies in prophylactic dosing of obese patients and found that a modest increase may be warranted. Because low molecular weight heparins are renally cleared, factor Xa levels increase with decreased renal function. The pharmacokinetics in renal dysfunction differs among the different low molecular weight heparins that are out there, and there's not really one creatinine clearance cutoff value that correlates with an increased risk of bleeding for all low molecular weight heparins. But likely a safe threshold is if your patient's creatinine clearance is less than 30, you should decrease the dose. And I've listed some examples of renal dosing using enoxaparin. Manufacturers of low molecular weight heparins usually recommend that if a patient has severe renal dysfunction, that you should avoid low molecular weight heparins entirely and just use unfractionated heparin. So when in doubt, you can always check on the anti-factor Xa level. Obviously, bleeding is a potential toxicity with low molecular weight heparin use. There's no proven reversal agent for low molecular weight heparins. Protamine only neutralizes about 60% of the anti-10A activity. So the recommendations are if a dose of low molecular weight heparin is given within 8 hours, you should give 1 milligram of protamine for each 100 anti-factor 10A units of low molecular weight heparin that you want to reverse. About 1 milligram of enoxaparin equals about 100 anti-factor 10A units. Also redose with 50% of the original protamine dose in 2 to 4 hours if bleeding continues. Heparin-induced thrombocytopenia, or HIT, is another toxicity that is associated with low molecular weight heparin use. HIT is an antibody-mediated adverse effect of heparin. There is less risk of HIT with low molecular weight heparin use than with unfractionated heparin, but it can occur. The effect is severe platelet reduction from heparin-induced antiplatelet antibodies, and there's also a risk of paradoxical thromboembolism from heparin-induced platelet aggregation. The signs and symptoms to watch for in HIT are platelet count reductions of about 5 to 10 days after the start of therapy or acutely in patients that are exposed to heparin in the past 100 days. Also watch for skin lesions at injection sites and any signs of a new thrombus formation. So you want to monitor platelet counts in patients on low molecular weight heparin, and you can test for HIT antibodies in patients with suspicious signs or symptoms. Any thrombocytopenia serious enough to cause bleeding should be considered to be heparin-induced, and any new thrombus can be the result of heparin. If you suspect HIT, DC the low molecular weight heparin and start an oral anticoagulant or an IV direct thrombin inhibitor for further anticoagulation. Now, the dosing of those agents is outside the scope of this lecture, but I wanted to mention them because this is especially important because these patients are hypercoagulable, so you still need anticoagulation therapy. Speaking of non-heparin anticoagulant therapy, the next agent we'll talk about is fondaparinux, or the brand name is Erixtra. It's used in the prevention and treatment of venous thromboembolism and also to prevent ischemic complications from unstable angina, non-ST elevation MI, and ST elevation MI. It's a factor Xa inhibitor like low molecular weight heparin. However, it's a synthetic analog of a unique pentasaccharide structure that is found in heparin and low molecular weight heparins that ultimately promotes the inactivation of factor Xa, leading to its anticoagulation effects. Like low molecular weight heparins, fondaparinux is 100% bioavailable after sub-Q injection. Its peak anti-factor Xa activity is about 1 to 3 hours, and it also shows a more predictable dose response than unfractionated heparin. This excellent bioavailability and lack of variability in the dose means it also can be used without the PTT monitoring that is required for heparin. It is also eliminated renally, so we'll need to keep that in mind for dosing as well. And in contrast to low molecular weight heparin, has a longer half-life of about 17 to 21 hours. Therefore, it can be given once daily. When dosing fondaparinux for prophylaxis, we use a fixed dose, shown here, and for therapeutic doses, we use weight-adjusted doses, shown here. There are a couple of groups of people for which fondaparinux is not the best choice of agent. It's contraindicated in patients less than 50 kilograms when used for prophylaxis because there's an increased risk of major bleeding episodes. And it's contraindicated in all patients when a creatinine clearance is less than 30 because remember, it's renally eliminated, and you can also see increased risk of major bleeding episodes in these patients. Some experts recommend decreasing the dose by 50% if the creatinine clearance is less than 50 mils per minute. It also shouldn't be used in pregnant patients due to insufficient data in that population. As you would expect, bleeding is a potential toxicity with fondaparinux use. However, it doesn't bind to protamine, so protamine is an ineffective agent for serious bleeding due to fondaparinux. In contrast to low molecular weight heparin, fondaparinux does not cross-react with HIT antibodies, and there have been no reports of HIT with fondaparinux, so it has been used successfully to treat HIT patients. Okay, moving on to our vitamin K antagonist, warfarin. Warfarin is used in primary and secondary prevention of VTE, the prevention of thromboembolism and atrial fibrillation and prosthetic heart valves, primary prevention of MI in high-risk men, and also in the prevention of stroke, recurrent infarction, or death in patients with MI. So, a lot of uses for warfarin. Warfarin inhibits vitamin K-dependent clotting factors 7, 9, 10, and 2. It essentially knocks them out of the coagulation cascade. Warfarin also inhibits proteins C and S, which C and S, they're two separate proteins, which are your body's natural anticoagulants, and I'll explain their role further in an upcoming slide. Now, warfarin doesn't directly inhibit the clotting factors. It's a vitamin K antagonist. So in order for these clotting factors to synthesize, they need the active form of vitamin K. This slide is a diagram of the vitamin K cycle. Starting at the bottom of the slide, vitamin K epoxide is the inactive form of vitamin K. Inactive vitamin K transitions to active vitamin K as you go clockwise through the cycle. Vitamin K hydroquinone at the top of the slide is the active form. So this active form of vitamin K is used in the synthesis of the clotting factors that we talked about. On the right-hand side of the slide, you see the protein moving to carboxylated protein. This represents the synthesis of the clotting factors. Active vitamin K is necessary in this process of synthesizing the clotting factors. Warfarin is shown on the left-hand side of the slide. It interferes not with the synthesis of the clotting factors, but with the vitamin K that's moving from its inactive to active form. If a reduced amount of active vitamin K is available, there is a reduction in the synthesis of vitamin K-dependent clotting factors. The clotting factors that are vitamin K dependent are shown here with boxes around them: 7, 9, 10, and 2. Protein C and protein S are also inhibited. As I said before, these proteins are your body's natural anticoagulants, and they exert their anti-clotting effect by destroying activated factors 11A, 8A, and 5A to inhibit thrombin formation and thus clot formation. So actually, by inhibiting proteins C and S, you're knocking out your body's own anticoagulation, which is important to understand because I'll explain why in an upcoming slide. But for the most part, after the inhibiting of the clotting factors is balanced with the inhibiting of the protein C and protein S, the end result is an overall anticoagulant effect. Warfarin is rapidly absorbed and has a high bioavailability. Patients rarely have absorption problems, except if your patient's on cholestyramine, it can bind up the drug and decrease the absorption. Its half-life averages at about 36 hours, so once-a-day dosing is adequate. It's very important to note that there is a 1 to 3 day delay between peak drug concentrations in plasma and warfarin's anticoagulant effect. This is because while you have the partially inhibited synthesis of the clotting factors, you have an unalterated degradation rate of those clotting factors. So you've got these clotting factors that were made prior to the initiation of warfarin that have to go through the normal time it takes for them to degrade, which happens to be a pretty long time. The factor half-lives are 6 hours, 24 hours, 40 hours, and even 60 hours. This graph really demonstrates it best. On the x-axis, you have time in hours, and on the y-axis, you have the concentration of factors in percentage of normal. On the right vertical axis, you have INR. At time 0, warfarin is given, and the squares are the INR as it increases over the first 5 days. The other shapes represent the vitamin K-dependent clotting factors. Now you can see that they don't fall all that quickly, and in fact, the percentage of them that are still around by day 3 is quite a bit. So true prothrombin, factor 2, represented by the circles, has a half-life of 60 hours, and it takes several days of therapy for this activity to reach the therapeutic range. Protein C and S, on the contrary, which are not shown in this graph, are actually inhibited much sooner. Their half-lives are 8 hours and 30 hours, respectively. And because by inhibiting protein C and S, you get a procoagulant effect, you have to be careful in those first few days because the procoagulant effect might outweigh the anticoagulant effect until more time passes and higher concentrations of the clotting factors, specifically 10 and 2, are decreased. So from this, we can see that with warfarin, the speed of onset is based on the half-life of the clotting factors and not the size of the dose. Loading doses cannot overcome the long half-life of the clotting factors. That's why we no longer do large loading doses at the beginning of therapy. It's reasonable to start with 5 milligrams daily for the first 2 to 3 days of therapy, and then base subsequent dosing on the INR. An exception is if you're going to use warfarin in an elderly patient. Usually start at lower doses, maybe 2 to 4 milligrams. The INR target varies per indication. In most cases, a moderately intense target of 2 to 3 is recommended, and there are some circumstances that allow for low-intensity therapy and high-intensity therapy, which we'll talk about in future slides. Genetic and environmental factors can also play a role in the patient's response to warfarin. There can be gene mutations and also drugs, diet, and disease states that play a role. For example, warfarin is highly protein-bound, about 99% bound to albumin. Warfarin can be displaced by drugs or any health state that lowers the albumin, such as malnourishment. Warfarin is also metabolized by the liver, so patients with liver disease may have a varied response. Bottom line is that warfarin requires individualized dosing and diligent monitoring. When you monitor warfarin, you're usually going to check the INR after the initial 2 to 3 doses. And stable dosing occurs, after stable dosing, you're probably going to check that INR every 4 weeks or so. Oftentimes you need more INR checking if you're adjusting the dose or if you're adding or discontinuing any medication. For dose adjustments, prescribers use typically clinical experience. Sometimes people have formulas or nomograms, but most people that use clinical experience make changes of about 5 to 20% of the total weekly dose to correct moderate INR changes. Remember to make your changes patient-specific. Keep in mind how they tolerated prior changes and even their compliance skills. Will a patient remember to take a different size dose every other day, or will they be more likely to take their doses as directed if you alter their regimen differently? These are some adverse effects to mention with warfarin. Skin necrosis can result from reduced activity of protein C and is usually seen in the first few weeks of therapy. Warfarin is pregnancy category X because it has demonstrated teratogenic effects to the fetus, and risks clearly outweigh the benefits of therapy. It is definitely contraindicated in pregnancy. Bleeding is obviously the big adverse effect that we worry about with warfarin. We can give doses of active vitamin K, which will increase the synthesis of the clotting factors to help reverse supertherapeutic INRs. The preferred route of vitamin K, if you're going to give it, is PO, with sub-Q as an option if the patient is unable to take PO. However, its response is less predictable and delayed compared to oral. IV by slow infusion should only be used when a very rapid reversal is required due to serious bleeding or a major warfarin overdose, and you don't really want to use it IM. Remember, just by stopping the administration of warfarin, it will also increase the synthesis of the clotting factors as well, because you're letting vitamin K activate itself again. Giving additional exogenous doses of vitamin K just kind of speeds up the process. But you have to keep in mind that if you want to re-anticoagulate this patient again, or drop a supertherapeutic INR back into the target range, if you give exogenous vitamin K, you actually may over-reverse your anticoagulation, and then it's going to take some time to get them back up to that target range again, as it did when you initially started the patient on warfarin. Here's a summary of recommendations for treating supertherapeutic INRs. The big thing to notice is that you're not just assessing your patient's INR, but any active bleeding or bleeding risk. So if there is a serious bleed at any INR, you should try to rapidly reverse the anticoagulation with vitamin K and fresh frozen plasma. On the other end of the spectrum, if your patient's INR is less than 5 and there's no clinically significant bleeding, holding warfarin for a dose or lowering the dose is an option. There are many drug interactions with warfarin. Warfarin is metabolized by cytochrome P450, so therefore there are many interactions with the drugs that affect the CYP450 system. They either can increase or decrease the warfarin effect. Really, you want to monitor INR more frequently when a patient begins or discontinues any medication, including over-the-counter medications and herbal medications. I've listed here some common offenders that can affect patients' INR through drug-drug interactions with warfarin. Since patient education is really so important with the warfarin use, I put together a list of some education points to cover with your patients when first initiating warfarin therapy. Just to highlight a few, they should take it consistently. So make sure that they know what to do if they miss a dose on day 1 and if they don't take 2 pills the next day. This is important with any medications, but especially important with warfarin. Also, have a consistent diet, especially when talking about vitamin K-rich foods. They don't have to stop eating foods with vitamin K in them, but just be consistent with their diets so they don't have big fluctuations of exogenous vitamin K coming into their systems that can affect their INR. Same with alcohol. They don't have to completely avoid it, but they just shouldn't do any binge drinking. Wear an ID bracelet or carry a medication card in their wallet so healthcare practitioners can see their warfarin, that they're on warfarin in case they are in a situation where they can't tell them. Also, have them talk to their pharmacist when they go to their drugstore to pick out some over-the-counter medication for their aches and pains or colds or whatever. Tell them to let the pharmacist know that they're on warfarin and to seek advice on what to choose. Go over any signs and symptoms of bleeding and what to do if they notice any: bleeding gums, bright red blood in their stool, nosebleeds, any easy bruising. And then also for your elderly patients, talk to them and their family members and caretakers about fall precautions. There are a lot of anticoagulation clinics that are out there. These are usually specialized multidisciplinary clinics that have a collaboration agreement with a prescriber. Studies have shown that these clinics may achieve better management than usual care. They can schedule labs, adjust dosing, and do individualized counseling and patient education. There are a lot of anticoagulation clinics that are out there. These are usually specialized multidisciplinary clinics that have a collaboration agreement with a prescriber. Studies have shown that these clinics may achieve better management than usual care. They can schedule labs, adjust dosing, and do individualized counseling and patient education. Rivaroxaban is an oral factor Xa inhibitor. It's the first of its kind in the United States, although it's been available in Canada and Europe since 2008. The indications at this time are for VTE prophylaxis, post-hip and knee replacement surgery, and for stroke prophylaxis in AFib. It's dosed at 10 milligrams a day, and it's excreted renally, so in your patients with creatinine clearance of 30 to 49, you should watch them closely and avoid using it in patients with creatinine clearance less than 30. It's hepatically metabolized by CYP3A4 enzyme, so you also need to avoid using it in your patients with moderate to severe hepatic disease. It doesn't require INR monitoring similar to dabigatran, so that's an advantage with using this agent. However, it also doesn't have an acute reversal agent like dabigatran. There is some research into if PCC can be used as a reversal agent. However, there's no recommendations at this time. Obviously, there's a risk of major bleeding with this agent, as there is with other anticoagulants, and caution should be used with other agents that can cause anticoagulation or antiplatelet activity. Because it's metabolized by CYP3A4, recommendations in most cases are to avoid this agent with strong and sometimes weak CYP3A4 inducers or inhibitors. However, with using it with inducers, you might be able to just get away with just increasing the dose of rivaroxaban. Also, it's important to note that decreased clearance and increased factor Xa inhibition has also been seen in older patients and smaller patients. And it's also important to note that this drug should be discontinued prior to surgical or invasive procedures. There is quite a price difference for your patients with AFib that need full anticoagulation. If you factor in the cost of the INR monitoring as well, it does seem more balanced, but it's definitely something to think about. For the last part of the lecture, I'd like to briefly discuss guidelines for anticoagulation therapy for patients with AFib. Our review comes from the 2012 CHEST guidelines, which is the most recent update of these guidelines. AFib is an indication which you might see and use anticoagulants and antiplatelet therapy in your patients. AFib is the most common significant cardiac rhythm disorder, and its frequency increases with age. It's uncommon in patients less than 50 years old. However, the frequency rises from the sixth decade onward. Nearly 10% of those people that are greater than 80 years old have AFib. It is an independent risk factor for ischemic stroke, and AFib increases the risk of stroke by about fourfold. And ischemic stroke is prominently the result of cardiogenic embolism. So anticoagulation and antiplatelet therapy is used to prevent stroke in patients with AFib. This slide is a summary table showing the 2012 CHEST guideline recommendations for antithrombotic therapy based on stroke risk. These guidelines apply to patients with persistent or proximal AFib with no current plan for cardioversion. The CHADS risk index is used to assess risk of stroke in patients with AFib. 1 point is assigned for each of the following risk factors the patient possesses: heart failure, history of hypertension, age greater than 75 years old, and diabetes. 2 points are assigned for the patient that has had a history of stroke, transient ischemic attack, or systemic embolism. Then you add up the points and determine which type of antithrombotic therapy is appropriate. So higher risk patients should receive an oral anticoagulant. Now the guidelines recommend dabigatran over dose-adjusted warfarin to an INR of 2 to 3, but either agent is acceptable. Rivaroxaban did not have an indication for stroke prophylaxis in AFib when these guidelines were being written, so the guidelines specifically do not address rivaroxaban. The patients in this high-risk category will see the largest benefit of oral anticoagulation over alternative therapy. So for patients who are unsuitable for or choose not to take an oral anticoagulant for reasons other than concern about major bleeding, and some examples of this would be difficulty maintaining a stable INR, or lifestyle limitations of regular INR monitoring, or dietary restrictions that are too burdensome, or the cost of some of the new anticoagulant drugs being too high. So for these patients, combination therapy with aspirin and clopidogrel provides an additional benefit of stroke reduction at the cost of additional bleeding. Patients opting for combination antiplatelet therapy rather than treatment with an oral anticoagulant should be informed that they're choosing an inferior treatment with regards to stroke prevention. Now, intermediate risk patients with a CHADS score of 1 should receive an oral anticoagulant if possible. However, the guideline authors admit that patients in this category will not see as large of a benefit from the therapy compared to patients with CHADS scores of 2 or more. And they say that in scenarios where patients are at high risk for major bleeding, patients may decline oral anticoagulation. So the big risk that we're worried about here with oral anticoagulation is over anticoagulation and bleeding. Now, although an increased INR with warfarin or over anticoagulation with the other agents can put these patients at risk for any type of bleeding, we're specifically worried about the risk of intracranial hemorrhage in these patients because it's really the only hemorrhagic complication that regularly produces problems as great or greater than the ischemic strokes we're trying to prevent. But again, if your patient falls into the moderate risk group, you must really talk to your patients and explain the benefits and risks of anticoagulation and what their options are. If your patient scores 0 points on the CHADS index, it's recommended that they receive no antithrombotic therapy. But for patients who do choose antithrombotic therapy, they may take aspirin. The reason no therapy or aspirin is recommended in the lower risk group is because the benefit of anticoagulation with an oral anticoagulant agent might not be worth the risks and the burdens of the therapy. This slide is a summary table showing the 2012 CHEST guideline recommendations for antithrombotic therapy for patients with persistent or paroxysmal AFib in which you plan to cardiovert out of AFib. Pre-cardioversion anticoagulation therapy is important because patients with AFib may have developed an atrial thrombus, and anticoagulation therapy decreases the likelihood that an atrial thrombus is present at the time of cardioversion. Post-cardioversion anticoagulation therapy is important because following the restoration of normal atrial electrical activity, the mechanical contraction of the body of the left atrium may remain dysfunctional for as long as 2 to 4 weeks after cardioversion. The duration of atrial recovery appears to be directly related to the duration of AFib prior to cardioversion. So for these reasons, in certain situations noted in the table, anticoagulation should be continued following conversion or cardioversion. So let's go through the recommendation table. Anticoagulation therapy recommendations are different depending on the duration of the patient's AFib. For patients with AFib for greater than or equal to 48 hours or for an unknown duration that are hemodynamically stable, it's recommended that they have 3 weeks of anticoagulation prior to cardioversion with a vitamin K antagonist or warfarin, a low molecular weight heparin at full VTE treatment dosing, or dabigatran. Again, rivaroxaban was not mentioned in these guidelines. Then, after cardioversion, follow with at least 4 weeks of therapy. There's always the possibility that a patient may flip back into AFib, so in patients with risk factors for thromboembolism, basically applying the CHADS to risk factor scoring system, anticoagulation should continue longer than 4 weeks, unless there's convincing evidence that sinus rhythm is maintained. Alternatively, you can use the potentially expedited approach of using TEE to screen for thromboemboli prior to cardioversion. Because the concern that the new thrombus may form during the peri or post-conversion cardioversion period, it's recommended to use at least 5 days of IV unfractionated heparin or weight-based therapeutic doses of low molecular weight heparin or an oral anticoagulant at the time of cardioversion, in addition to a multiplane TEE. If there is no thrombus identified, you cardiovert and then you give at least 4 weeks of anticoagulation. Again, continue longer than 4 weeks unless there is convincing evidence that sinus rhythm is maintained. Now, for patients with known duration of AFib less than 48 hours that are hemodynamically stable, no prolonged anticoagulation is necessary. It's recommended to begin IV unfractionated heparin or weight-based therapeutic doses of low molecular weight heparin at presentation, then cardiovert. Post-cardioversion anticoagulation and long-term anticoagulation is based on whether that patient has experienced greater than 1 episode of AFib. So do they flip in and out of AFib, essentially, and then also their risk factor status. For patients with any duration of AFib associated with hemodynamic instability, cardioversion should be performed immediately without delay. You begin IV unfractionated heparin or weight-based therapeutic doses of low molecular weight heparin at presentation and then cardiovert. These patients should receive at least 4 weeks of anticoagulation and possibly longer based on whether the patient has experienced greater than 1 episode of AFib and their risk factor status. Again, to review these guidelines, you can refer to the CHEST guidelines. This slide is a summary of the 2012 CHEST guideline recommendations for antithrombotic therapy for patients with prosthetic valves. You can refer to CHEST guidelines for specific details, but in general, for the purposes of this lecture, just know that there can be a difference in target INR and duration of therapy in patients with prosthetic heart valves, and that aspirin is recommended in addition to vitamin K antagonist therapy in patients with a mechanical mitral or aortic valve unless the patient has a high risk of bleeding. The term venous thromboembolism includes deep vein thrombosis, or DVT, and pulmonary embolism, or PE. The risk of VTE can be broken down into two types of causing factors: hereditary and acquired risk factors. And there are some examples listed here. Sometimes IV unfractionated heparin is used to treat VTE, but since our focus is on the ambulatory care setting, we'll talk about the options you'll see in that setting, such as low molecular weight heparins, fondaparinux, and warfarin. The recommended dosing for low molecular weight heparin is weight-based, usually started in the hospital after diagnosis. The doses for that are listed here for enoxaparin, dalteparin, and fondaparinux. You can continue low molecular weight heparin in the ambulatory care setting, or you can transition to warfarin therapy with an overlap dosing, with the target INR for the warfarin therapy would be 2 to 3. Now, remember when we talked about how in the first few days of warfarin therapy, your patient might have an overall procoagulant effect because protein C and S are depleted first before the clotting factors? Well, that's why we want to make sure that there's an overlap with low molecular weight heparins and warfarin during the first few days of therapy. This overlap may not be as important when starting warfarin therapy for prophylaxis of clots, but it can be very important in the treatment of existing clots. We don't want to make the situation worse. So you would start the warfarin and the low molecular weight heparin or fondaparinux at the same time, and then as the warfarin, and then DC the low molecular weight heparin or the fondaparinux when the INR is within target range of for about 2 to 3 days. This is a simplified summary of the recommendations for VTE treatment duration according to the CHEST guidelines. For an initial VTE event, whether it's proximal or distal, if the event is provoked by surgery or another risk factor, you would treat for at least 3 months, longer if the risk factor is not resolved. For unprovoked or idiopathic VTE, you treat for at least 3 months, unless it's a proximal VTE and the patient is low to moderate bleeding risk. For those patients, if risk factors for bleeding are absent and good anticoagulation monitoring is achievable, it's preferred to keep them on long-term treatment. For recurrent VTE, patients should be on long-term therapy unless they have a high bleeding risk. For patients with active cancer, it's recommended that they should be continued on long-term treatment due to higher risk of recurrence. In this slide, I just wanted to specifically review therapy for VTE in pregnant patients. As a reminder from previous slides, warfarin and fondaparinux are contraindicated in pregnancy. Low molecular weight heparin is preferred until delivery, and patients should switch to IV unfractionated heparin 24 hours before anticipated delivery. Unfractionated heparin has a shorter half-life for quicker reversal in case of an emergent C-section or something like that. Warfarin should be started postpartum and continued for at least 6 weeks postpartum. The total duration of therapy for the patient should be at least 3 months. This concludes our discussion on the pharmacology of antiplatelet and anticoagulant drug therapy, and I thank you for your attention.